Or as John Cleese would say, and now for something completely different. I think Ellen and I both thought that while there are a lot of issues with mesh, one of the biggest ones that nobody really talks about is what mesh can you use? And some of you in the audience are probably lucky and can say, I want this, and your hospital will get it for you. There are others of us who were told, you can pick from this, and that's it. So this talk is to explore those issues a little bit. So if you're in that situation, your response is probably, why are you doing this to me? Why are you tying my hands? I go to shows like Sages, I see these wonderful meshes, all these reps come in, they tell me how great their mesh is, and I can't use them. So there is a reason this is happening, and we're just gonna talk briefly about the context and environment, and then we'll talk about strategies for dealing with limitations in your practice. So why is there limited choice? Well, pardon my rather, I guess, elementary animation, but it's money. And money is important today. We all know that. So there was an excellent talk by Scott Roth during the postgraduate course, and I encourage you to look at the slides on Event Pilot. It's on your, if you haven't noticed yet, on your app, you can see a lot of the slides that were presented for talks you missed. And Scott was very kind and allowed me to share a few slides from his presentation because I really think it helps set the context. So they managed to get financial data at their institution, which if you've ever tried to do at your own institution can be unbelievably difficult. It's like a big mystery how much money is being spent. But here you can see they actually took ventral hernia repair data. They got full, as thorough as they could, they checked the costs. And the blue bars are patients who came in for a hernia repair. The red bars are patients who their primary DRG was maybe a colon resection or some other procedure, and they had a hernia repair as part of their procedure. And what you guys have probably already noticed is that the one column called profit is negative for both groups. It's just more negative for the secondary repair. And when they broke that down some more, you can see that they've looked at all the different parts of the cycle, what the hospital's revenue is based on the DRG, what the direct costs were in terms of the personnel, the supplies in the OR, the costs in terms of indirect, so the expensive equipment at the hospital, and again, profit. So you'll notice that the one profitable group was a patient who was brought in as an inpatient for a synthetic mesh repair, and they made on average $60 of profit. Every other group was negative, especially an inpatient who had a biologic mesh. Now that patient probably required a lot of care, but we have to think about our materials and what the contribution of our materials to that cost is. And this was published by our mother group, the American College of Surgeons, in 2013. So this is a primer, and it is primer and not primer. Primer you put on the wall. Primer is something Laura Ingalls Wilder used. I looked it up to be sure. So this is a primer for understanding the alternative physician payment approaches and what is going to be affecting all of us as we practice in the future. So essentially, what we're looking at in the future is there will be bundled payment, and that means that only a single payment is going to be made, and everyone involved in the care of that patient is going to be fighting for their piece of that pie. Now, the goal of that is to encourage providers to coordinate care and delivery and to work together for more efficient and more cost-efficient care and to have the outcomes be better for the patient. And the thought is the money you save in the process gets put back in the physician and the doctor, in the hospital's pocket. We shall see. But it started. It's happening right now. So this was part of the ACA, and this is a current map I took the other day off of the website for CMS in terms of bundled payments for care improvement initiative. Okay, so all those blue dots are people already participating in a bundled care program. Now, it's not for everything. It's just for very selected disease criteria. But here's my hospital. We have several things so there's 4 categories that you can participate in, and we are already doing bundled payment for joint replacements, congestive heart failure, and cardiac catheterization at my institution. So it is here. And this was the general surgery coding group that sat down and put together a long list of what they thought would be appropriate procedures for bundled payment. And it's a long list, but I think we're going to start seeing this affect us in general surgery in the future as they gain more experience with the other types of procedures. So that raises the question of how much do our materials cost and how do we acquire them? So some of you in the audience are probably very familiar with this, some of you might not be. Almost every one of your hospitals is probably part of a GPO, which is a general purchasing organization. And these are professional procurement organizations. They have different owners, there's different types, but essentially what these groups are doing are consolidating purchasers to gain economy of scale. So buy in bulk, pay less. And there are lots of different cost and contract structures available with each of these GPOs. So this is an example. You can have potentially 3 tiers with a particular contract. So at the bottom row, it says what $1 million in product is going to cost the hospital. So if you're in tier 1, that's the free-for-all, you can have anything you want, okay? There's no commitment, but there's also no discount. You are paying wholesale, or paying full retail price, essentially. In tier 2, we start seeing that there is some limitation of what you can use. So your hospital is saying, we commit to using 60 to 80% of our need for mesh from this specific supplier. And in return, you get either a rebate or a discount. So now you're only paying $850,000 for that $1 million of mesh. And finally, in tier 3, it's kind of the worst in terms of commitment. You're really restricted. You're saying, I will use over 80% of one company's mesh, but in exchange, you're getting 30% off. And so this is the best tier for pricing. Now, what's also interesting is I started talking to some of my reps and asking them about the discounts. And mesh is actually one of the worst discounts in the market because the companies predict that they have worse commitment. They think we can get much better commitment on things like endomechanical and suture, and so the discounts are much greater, up to 50%. Now, I mean, I don't know if it's like, again, retail, where they expect they're going to slash prices by 50% about 2 weeks into the season, so you come in and buy, and so they price it higher. But mesh doesn't get as much discount because they don't expect to capture as much of the business. So that was for illustration. It can get even more confusing because you can go outside the GPO and subcontract directly sometimes with a company. So here is an example, and this is vendor neutral, but this is data I got from people in my supply chain management. So you can see that my institution had an annual spend of $2.6 million on biologic mesh, and that 51% came from one particular vendor. And if you look back at our last slide, that doesn't put us in any tier for discount at all. So we're paying essentially face value for that mesh. With synthetics, it's a little better. We're maybe in that middle tier because we're using 65% of our product from one company. But you can imagine if the cost of your mesh is going to start cutting into what you receive in reimbursement as part of the bundle, it might make you think more carefully about what mesh you're going to buy. And if you want to stay within that third tier where you get the discount and more of the available funds are staying for maybe the physician's fee rather than for the cost of the mesh. So in that scenario, how do we deal with it? And I think what we have to do is think about where we use mesh and what kind of mesh we use and make intelligent decisions about the choice. So, you know, rather than saying you kind of want to, I'll take one of each thought to it. So what are your high volume procedures? Probably your inguinal and ventral hernias. There's going to be variation in your technique. So obviously in any extraperitoneal space, you can use an uncoated mesh, whereas when you're working intraperitoneally, you need a barrier. There are some special procedures to consider, parastomals, where you need to have coating on 2 sides of a piece of mesh if you're doing it laparoscopically, emergency procedures, and contaminated procedures. And so if you just think about your mesh basics and break it down to what's available, you can then say, what is important to me about the characteristics of the mesh? And this is from one of Corey Deacon's papers, which I highly recommend people take a look at. It helps talk about, again, the different weights of mesh, the interstices, and then if you want a medium weight mesh, you would need to say, what is the medium weight mesh available from my vendor? And there's some meshes where you may not want that particular mesh profile if you think it's too light, but you need to decide what works for you. We talked about some of the special cases. You might want to look and see if the company that your institution has a contract with has these available, or if you need to, pay wholesale for them if you need them. So I just recommend educating yourself, set up a meeting with your rep. When I got to my new institution, I had to change meshes, I had to change companies, and I started poking around the shelf, and I realized everyone in the institution was using the heavier weight mesh for lap inguinals. I said, well, why don't we have this other stuff? And they said, well, no one ever asked for it. So I asked for it, and now most people have switched to the lightweight material, but they just didn't know it was available in that company. So talk to your rep, look through the catalog, look for what else is out there for what fits your need profile. Know how your institution works. Find your supply chain management people. Find out how you get a new piece of material in. I can't bring in anything new to my institution without going through my value analysis committee. But if I can prove that it's an unmet need from the company who we work with, then they will allow me to use it. So find out what those rules are, and just make sure, a lot of places now you can't just walk in with a donation piece of mesh. There's more restrictions than there used to be. So thank you.
That was great.